Um, so before you guys got in here, we talked about medication that's not covered by our Medicare, and the way that's being carried out is that certain medication like the blood thinners and the diabetic medication are going to be carried out in such a way that when you see it on Matrix, it'll note in there, do not refill, right? On the special instructions on some of these medication that's not supposed to be refilled through the pharmacy, it's going to indicate please call family members. Okay. Of course, if we need the medication, get it from the e-kit. Get it. Call the pharmacy. We'll pay for it. Ask for 7 days. But we should be following up with family members. If it says on their matrix that says, hey, family member will refill. Huh? You need to call the family member. Call around and say, hey, let me get like a couple days of this, and we'll pay for it. But the next fill should be through the family member. Okay. I'm gonna work with Sandy to make sure that these medications are ordered the correct manner.
And if you're busy, you can ask me too, and I can call for you if I'm here. And then also just FYI, Dr. Vu has been really good about like the meds that, like if the family says, oh, I don't have any left, Dr. Vu's been really good about ordering from their pharmacy, and then the family picks it up and brings it in.
Okay, Ja is gonna talk about ITSE and a couple topics. You want to talk about? Okay, all right. So we're limiting our topics, guys, to like a handful instead of a lot, because we're going over 1 hour. So let's go over this real quick. First one is the EDC. A couple weeks ago, maybe even a month ago, we required everybody to watch a video in IDSE, which is the new platform for the residents' dietary order. So in the last couple of days as well, we started to add circles in residents' name outside their room. You'll see that in addition to the fall little red dot, you'll see right after the name, you're gonna have 2 circles, and they're color coordinated. Okay, and the first circle is going to indicate the resident's diet order. Okay, whether it's puree, whether it's regular, food texture, as Josh said, but it's going to tell you basically based on this little pyramid right here. I'm going to show it on the video here because this PM meeting is going to have a little bit more than the knock. And anyways, you're going to need to kind of familiarize yourself with this, what the color indicates. Okay, like the green one says puree, and then the second color, the little circle, is going to indicate the order for the fluid. So it could be thin, it could be nectar thick, it could be honey thick, but the green one, it says extremely thick. The yellow one says moderately thick. So it could be yellow, liquidized, with another yellow, which is moderately thick liquid. Okay. So if a surveyor asks you, it's like, hey, what does the red dot right before the name means? That's the fall risk resident, right? The high risk for fall residents. Okay, and we have a little platform for that as well, right? And this is gonna be made into your name tag. We're gonna attach it to your name tag. I'm gonna have we're gonna make about 100 of this, and we're gonna give everybody one. Okay, but the 2 little red dot right after your name is gonna indicate the diet order, and then the also the liquid order. Okay, so we're gonna need to also tell the surveyor this is what it means. Okay, and if you forget, you can always flip over your name tag and say, okay, this is what it means. And if you lose this, we should have it at the nursing station and also at the dining room. We have that all over the dining room, but also not only that, we have it on your narcotic book to kind of refer to. Yes, I know your question.
So on that little thing, is it looking gray or is it looking black? See, these kind of look black. And technically in the other picture, it's gray. I put them all up as black, so I don't know if we can just keep it as black, or do we need to switch them all to gray? Because
what the color that you have is gray, right?
no, I put up black because it looked black to me.
Which black? The white.
This one, the liquid, slightly thick.
I thought you said we didn't have any slightly thick people.
We don't right now, but the on that it looks black. It doesn't look gray.
Right.
So I'm just saying, going forward, if it's gonna look black, I'm gonna put black stickers instead of gray. Right?
It's not gonna matter because the second part is the fluids. So whether gray or black. I mean, I would rather use whatever is on here, so people
Yeah, it looks
don't
black.
get
Yeah.
confused.
So there's two pyramids, guys. Says foods and drinks. Okay, and
No,
there's
it's not, okay, let me,
Okay.
okay. So,
Food texture.
this is food, it says food, and the other part says fluids, okay?
Fluids.
This has to do with texture only. It is not the diet, therapeutic diet, so just, by looking at just this, you don't know if it's like a no salt added, renal diet,
Wow.
that, it will not show that. So do not tell the state surveyors, this is their diet order. It's not.
It's only the
Okay, it's only the
Texture.
texture, okay?
I'm still
So-
learning it too, as well. So,
Right.
sorry.
So, and then unfortunately, this doesn't have anything to do with the fluid restrictions and a lot of the other things that we do need to kind of know, but at least this part, because, and the reason why I insisted on this is, I'm really actually looking at more of the fluids, although also the, you know, the foods, because, you know, oftentimes there are people, especially with rehab patients, where the family will bring in, because the resident happens to be like an aspiration precaution or something, they've been put on, and let's start just using the ITSE terms. Let's say that they're on moderately thick, which I think is equivalent to
Kinda like
honey
nectar.
thick.
Nectar.
Is it nectar thick?
Kinda like
Anyway,
nectar.
but they'll just bring in just thin liquids, right? So once we kind of get used to this, if we see somebody has brought it in, I'm hoping that, you know, we can just like pull it off and it's right there on the door. I want the CNAs to get used to this also. I promise you, it may seem weird right now, but once we get used to it, there aren't that many different colors. It's like 8 or 7 or whatever it is. It really is. So I'm hopeful. The one other thing that came up this morning is Ricky or whoever's doing the admission, who gets the diet order, which includes the texture for food and fluids, they should be the ones who are putting on the little stickers, okay? Food's gonna be on the left, fluid's going to be on the right. Now, it's going to be the response, whenever there's a change in the textures, right? To the food or the thickness of the fluids. Whoever takes off that order must go and change the dot color, okay? So for our long-term residents, we shouldn't have to change it that often, but whoever takes off that order, don't assume somebody else is gonna do it. Don't assume that the unit clerk is going to do it, the secretary is gonna do it. Don't assume the next, you know, the resource nurse already did it or whatever. If you take the order off, when you note it, if you're the one who's putting in that order, go grab those little sticker dots and you put it on, okay?
And can we do the same thing with the fluid restriction? Like, I went around and I put all the fluid restriction on the whiteboards. And I'll do it, like, if the admission comes in, if whoever does the admission can put it on if there's an order, or if they take an order that they start them on a fluid restriction or something, to put it on the board as well.
The whiteboard.
Yeah.
Okay, we'll try that. That said, I mean, I just really feel like whoever's taking off that order should make sure whatever needs to get done needs to get done.
Yeah, that's
Because,
what
and it's not gonna take that much more time, although you'll have to walk through the room, but like, you know, when you take off a diet change order, you have to put, fill out that little yellow slip, or does somebody, then put, there are a lot of things even with just one order, right? So I'm sorry that I'm putting one more thing on you guys, but it's, if the person who's taking, you know, the order doesn't do it, it's just gonna fall apart. The whole thing's gonna fall apart. And John's biggest fear is surveyor's gonna come in here, they're gonna see like a black dot and a white dot, which is like regular and thin liquids, and this person has been made into like moderate thickness or whatever,
want me to-
slightly thick.
Do you want me to audit it every so often? Because I get a list, you can run a report and it's really easy just to walk around and double check. It didn't even take me that long to put them up,
That's fine, you can make this survey if you want to.
like monthly.
So, that's that, okay.
Okay, yeah, so carrying out change of orders, remember, change of orders, change to the diet, change it on matrix, change it on the patient's name and by their door, okay? Alright, what else do you wanna mention, Jeff?
Okay, I'll just mention, so the IVs, if you are, as an LVN, if you're IV certified, you went through that course, I don't care how long ago it was. And, with our nursing competency, every year that we do, I think all LVNs and RNs all go through the IV thing too. So, I know we haven't been letting you guys like, start IVs, discontinue IVs, hang, fluids, but you can. Okay, you can do flush, you can't do heparin, but you can do flush, you can hang any just regular fluids, but nothing, pardon me?
Just for hydration.
Just for hydration, but John pointed out this morning, and I said I would check on this, but I didn't, but I'm sure it is true. You can't hang anything if it has KCl in it. So, and you can't do like, antibiotics or whatever, but everything else that we have here, pretty much, you guys can do, okay? Including start, DC,
Do we have
flush.
anything to like practice on? Because it's been a while, and like I don't mind us to have a patient.
We
trying-
do, I
But-
mean, and that's one of the check-off things, so,
The one that we have though, it's not very like realistic.
I don't care.
Right,
You know what I
yeah.
mean? Like they have the ones. I don't know if we can get them on Amazon. It's like a smaller thing, and it has a bunch of different veins you can in different sizes. So you can kind of practice. I was gonna buy one just because I was so uncomfortable the other day trying to do one.
well, it's really difficult on these older patients. My biggest, advice for any of this starting an IV is to just use a blood pressure cuff, the old ones, to pump it up instead of using just a regular tourniquet. That really works well. It worked for me all the time, even on 98-year-olds with like absolutely no veins. So that's the IV. Call lights I talked about a little bit, and call light response time is getting, it's really good. It's really good, but just please make sure that if you do see the call light not being answered, answer it yourself. Get somebody to go and answer it. Did I have anything else? Oh, so I think, John, you already mentioned, right? So the pharmacy board is coming tomorrow. And it doesn't have to do with us, it has to do with Ron's. Shabnam asked us to like clean up the med room and the carts because the pharmacy board is doing whatever they need to do for Ron's. So if they don't pass, that's bad for us since they provide our meds. So I think Ricky cleaned up the west cart, she's starting to clean up the east cart. Hasn't gotten to the south cart, Helen, that's why I said I'm so sorry. And supposedly they are coming tomorrow. We do have the fridge in the med room locked. We noticed that it really sticks with the key, so you have to like press down and then, I don't
Twist.
know.
Twist right, twist clockwise
Yeah, but
to
you have
lock,
to press
and
down
then
first
counterclockwise to unlock.
open? Oh,
Yeah.
okay, so that's
Yeah,
upside
the
down.
refrigerator in the bedroom is what was.
Yeah. So it's locked right now,
I didn't know that.
and, if you guys have time to destroy any meds, because I think Ricky has like a bunch of meds, otherwise, call me. If you leave and, or when you guys leave tonight and you guys haven't been, if you haven't been able to destroy it, or you don't think that the, knock shifter will be able to destroy it, and these are mostly expired meds, okay? Somebody like text me so I can come at like 6 in the morning to just like hide it in my office, or,
Do we know what time they're coming tomorrow?
have no idea. And now it's not, like, I could have sworn it was tomorrow because that's what John said, but then,
Fourth, yeah.
so. And the wine is in where?
The wine and the alcohol for the resident, I think it's like a beer, is in my office. The refrigerator that was supposed to have been brought over to us, Activities took it, so they're gonna buy us a new one.
Okay.
So that's why I didn't see it last Friday. Was they delivered it and then
And
for
then
some
they just
reason I was
stole
like,
it?
oh, I'm so glad we got one. They're like, so I told Chris, I'm like, well, that was for us. That was for the alcohol for the resident. They're like, I was like, if you want it, you're gonna get billed for it, and then we're gonna get our own. So
Okay, I mean,
Yeah.
as far
Wednesday
as,
at 10:30.
as far as I'm concerned, 10:30?
Yeah.
Okay, then I'll have plenty of time. I'll be able to see, just don't bother like texting or whatever. So, the alcohol, we've always kept it in the bedroom. I don't have a problem with that. I don't think there's anything wrong with that, but I guess the pharmacy, board does have a problem. So as soon as they're done, we can just put it back in the bedroom. What do I care? So,
So
and then-
tonight we still have a wine in the men's room fridge?
No.
No, not tonight.
It's in my office.
Tonight.
Oh, your
It's
office,
in
okay.
this office, just because we weren't sure before, but anyway, so I don't have to talk about any of these other stuff, right?
Yeah, you wanna talk about the summary GG or has to match? Not matching.
Well, but
Yeah.
just tell them about that after you,
Make a
because
journey.
we're gonna go through that, right?
Yeah.
Essentially, this is it, what I was telling the other folks this morning was, because we're really going to come down on trying to improve our Medicare charting, what I was saying was, with the weekly summaries, it's so easy to just, copy, import from last week's or whatever, and then, I mean, I used to do this, I got kind of, lazy, and especially if you're working at nights, I didn't know how these people were walking around during the day and stuff like that, so I'm just assuming blah, 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 and, there would be times when I couldn't really go in and see the other notes, and sometimes when I tried, I would get no information, right?
But there's no changes within the week.
Right, right. But, so, when I started looking at some of these Medicare charting, and then I was looking at some of the weekly summaries, they didn't match. And the reason why I even got on this, campaign about we've gotta get the Medicare charting done correctly is because Dr. Mon, you know how she works at Carlsbad by the Sea? Anyway, the feds came in, that CMS, not the state surveyors, but the federal people, and they did a audit of their Medicare patients, their rehab patients, and I guess they drove them nuts, and they were in there for over a month. The only time that they are really going to come in and spend that amount of time is to try to claw back the money that they've already given to the facility for taking care of Medicare patients. So, I don't know if, at first I thought, with Donald Trump getting elected and he hates administration, the agencies and stuff like that, so I thought, yay, maybe we'll get a break, but then he's putting in, I guess, RFK or whatever. So I just don't know, and I just need to, well, it's actually Elon Musk who's going to cut Medicare and stuff like this, so who knows, maybe he'll say, hey, go after the, whatever. So-
We kind of talked about doing the assessments instead of the charting, since that hits all the areas for the skilled need for the system. And I know, John, you said you were gonna talk to Doc to see about having the cardiovascular, because that makes it easy.
Yeah, what she's talking about is opening, basically, instead of opening an observation specific to the diagnosis. And so, for example, a patient is admitted for COPD, she wants you to open an observation related to respiratory.
And it has,
So-
and it's kind of time consuming the first time you do
But it
it.
doesn't show up in the progress
Yeah, it
notes,
does.
right? It
Uh-huh.
does?
It shows up as an assessment, and then
You can connect your progress notes.
and so
Thank
it's
you.
literally just
And
click
your
boxes,
vitals.
but it's specifically targeted to the system. So if we put, the little book we have, that says why they're here, if we put down on that what system,
Yeah. And
then
you can
they
open
would
an
fill that
observation.
out, and the nice thing is it does copy paste. So for the nurses that are working regular, it'll save everything, you just go in and change what's different that day, and it's more detailed, it's gonna hit at all the areas for skilled need.
Yeah, I'm not sure about how that would.
That's
And then
a
it has
work
a
in progress.
bottom, it has this bottom
Until I
section.
can figure out the matrix and trying to put together these observations, put it all in one like area, because right now their observations are everywhere. And so I'm trying to talk
Well,
to
just
Matrix.
one that's not there.
Yeah, and so if you open up another observation, I would like for it to kind of populate in one area. So problem is, you add another observation, it goes everywhere, and the nurse is gonna be like, where the heck is it? You know, you're kind of looking in like multiple areas. So I
let's-
still need to kind of work on
Let's
that.
make that like an intermediate, like, goal,
Okay.
but in the meantime, like, this is something, like, what John's gonna talk about is something that we can start doing like right now, because it's just Medicare
Yeah.
charting. And I don't think I have anything else to say. Anyway, so, yeah, I want us to really focus on charting for next year, what I was telling the morning, the folks at the morning meeting. I am going to have to like really, audit these things, look at it, don't be offended if I come to you and say, hey, your charting isn't like really great or whatever, because I'm gonna be doing that a lot. So it's not just you, I'm probably going to be telling that to everybody, okay? So I'm going to try to really focus on our charting. I know Barbara tried, I know Nancy tried, so if you guys if you have an idea as to how to help you guys be better at this charting, or how I can support you, and one suggestion obviously is what Ricky just said, figuring out this observation thing. We'll try to work on it, or John will try to work on it, but I'm not good enough with Matrix to know if it's
Or
doable,
even
not
just like
doable,
a
or
printed
whatever.
pathway or something, so that people are hitting the right spots.
We used, Barbara had this thing, and I can like, hand it out to you guys, you may already have it in your, count book. I can give you that, whatever. It doesn't have to be today. If you come up with some idea later on, just tell me, John, whatever, because you guys are the ones who are doing the charting. So you would know what would be the most helpful. See, so for example, today, like, in all fairness to you, Ricky, but if I had to open up an observation, that would drive me nuts. I wanna just, I'm old school. I wanna just go into a progress note and just chart, right? I think that would be the most helpful to me personally, would be if I just had a template someplace, even if it's in a Word document or whatever, where I could just copy it, paste it in there, and make the changes. To me, that's how
I know, Matrix, I don't know why we don't have it, but there's a Matrix, you can have smart phrases, where you can save your own stuff. I used to do it. You can save your own templates. I don't know.
Don't know, because we got the
Yeah.
cheaper version. So,
Let me go over real quick Medicare charting, guys.
okay, and you don't need me for anything else,
No,
right?
you good.
Okay.
Yeah. Okay. Let me go over real quick Medicare charting, and I'm gonna show put this right here. It seems like it's like there's a whole lot of stuff in here. It actually is not. Okay. And again, it's Medicare charting requirements. The first thing when I was working as a nurse on the floor, the thing that I kind of remember in terms of Medicare charting that I always wanted to know before you even start charting is you need to have the diagnosis in there. Right? What do they get admitted for? Is it respiratory? Is it status quo surgery? Is it infection? Okay, get that underway first. And then obviously you're gonna look to see if there's a skilled therapy order on there, right? Your vitals, you wanna get that kind of like in place in your mind. Are they A&O times 4? Those are really important. How are they transferring? Because as you're working and passing your meds, you can see that the patient requires either times 1 or times 2 kind of transfer, right? When Medicare is looking at how you're charting, they want to know from admission how many, what kind of assist did you have? Upon admission, it's two person. Those are really important stuff in terms of Medicare. How is the patient progressing physically, right? 2% assist upon admission. Now discharge, they're independent. That's the progression that we want to see, right? But that has to reflect on your progress notes, right? On your notes as Medicare. Okay, so let's take a look at this real quick in terms of Medicare charting requirements. Resident condition orientation. You want to add that on their vital signs. Medication administration. Did the patient take all of his meds? Admitting diagnosis. This is what we're kind of like hitting on. All right, get those admitting diagnoses in. What do they get admitted for? Get those facts correctly in your head. Treatment and procedures. These are just like minimal stuff in terms of treatment that you did in your shift, if any, right? Activities of daily living. Did they participate in activities, right? Did family members visit them, right? What I added on here doesn't mean that you're gonna be like putting a whole like freaking like whole summary on it, right? These are just ideas of what you should be writing on with your resident. Okay, therapy. Are they on skilled therapy? Pain management. Of course, you're gonna mention in there. Are they having pain? Right? It could be it could be like patient. There's no complaints of pain. That's it, right? Intakes and output. Did they eat all their food and meals? Right? Are they voiding correctly? Did they remain continent or incontinent? Right? And then safety. Do you have something in there for safety? Okay. So on my little example here, I put down patient remains A&O times 4 with stable vitals. You can put stable vitals because the vitals is already on matrix, or you can put it in there yourself, right? You can put it on your nurse's notes. If there's questions like how do you know if it's stable? Well, it's on matrix. The CNA's already put him in there. I already put him on there. So you can put stable vitals. The patient took all their meds without issues, right? Or the patient refused medication. You can add that on there, right? So you've already covered vital signs and medication and the condition, right? And then we're gonna hit up on their diagnosis on O2 via nasal cannula at 2 liters per minute. And then if somebody's on O2, you're always gonna mention head of bed elevated, okay? And so that's the diagnosis, right? And then what are you doing for the diagnosis? What kind of medication are they taking? Are they taking antibiotics for respiratory distress or for some kind of pneumonia? No complaints of respiratory distress on this shift. Breathing is not labored. And then we gave Duonev as ordered, right? Or they're taking antibiotics. But if you're taking antibiotics, you want to mention also if they're having adverse side effect from antibiotics, right? So those are just like stuff that we already know, right? As nurses, we've been charting on this for forever. I know Helen's been a nurse for a very long time. She knows all these stuff. These are just common stuff that we write on a day-to-day basis. Wound care to left lower extremity. Maybe you add on there that you did a wound care, right? Maybe you did it. There's no wound care. You didn't. Skin is intact, right? But you need to add something in your progress note. Resident is up for all activities they shift, right? Maybe you want to say, hey, the resident just stayed in bed. We tried getting her up and she didn't want to. She declined, right? Oh, you saw that she participated in activities. You want to add that on there, right? Just work quickly. There's nothing special here where you're writing down a whole summary that the patient was in the bathroom and used 2 toilet paper. No, it is very it covers everything, and you're leaving out the fluff, right? She requires extensive assist times 2 staff with transfers and showers, independent with meals after setup, right? These are stuff that you've never heard before. I mean, these are stuff that you see all the time, right? And then you're mentioning pain with patient given Tylenol for mild pain times 1 for headache, or maybe you didn't give any, right? The patient had no complaints of pain on this shift, but you got to mention that, right? She consumed 100% of her meals, or maybe she declined her meals today. We gave her some nourishments, right? She remains continent or incontinent, right? And then she voided times 3. There's no signs of dehydration. If she did have signs of dehydration, you had vitals that's kind of like out of whack, right? And then she remains a fall arrest. So this is what we're doing for fall, right? Very simple, easy stuff. He seems very like, oh man, there's so much stuff on here, but no, it's just the same crap that the same stuff that we say on a day-to-day basis. You know what I mean? And but like if you grab a hold of the information that this patient was admitted with CHF, and then this is A&O times 4, and she's got stable vitals, and she requires extensive assist, you already got everything, because the vitals are there anyway, right? You're gonna know whether you did treatment or not. So I mean, these stuffs are easy. I mean, in terms of, and then for the next day, and I'm not saying you cut and paste, but I mean, it's pretty much the same stuff, for the next shift, right? And so our charting for Medicare has to happen every shift 3 times in 24 hours. Okay, every shift has to do it.
One
Okay.
thing, John, that we
Yeah.
that's an issue everywhere, just FYI, is when you're just starting the no side effects and adverse reactions, like, we need to be talking about the infection itself, like, if it's worsening, like, if they're a UTI, what does their urine look like? You know what I mean? It needs to be
Yeah.
a little more specific to the system.
Right. Oh, yeah, but UTI, yeah, but
Or
she's
if
taking
it's
it for, yeah.
pneumonia, like their lung sounds, or I don't know, maybe
Yeah.
maybe I'm too.
Yeah, and so that, like I said, you have to really be focused on the diagnosis that they came in, but yeah, if anybody who has acute respiratory distress, COPD, they're gonna want to know. They want that head of bed elevated. Okay, they want to know, the O2 saturation, and that you put it on continuous oxygen. You're checking oxygen every shift. Okay, So, I mean, these are just given stuff, you know. UTI, obviously, right? Fever, pain, are you voiding, are you incontinent? Holy catheter, draining well, right? You're pushing fluids, whatnot, you know. If they're antibiotics, you know, what are you doing for that antibiotics? You know, so these are stuff that we already know. I mean, and then we're just making sure that we're charting it, putting it in there. They want to see it, and right now we're not doing that in terms of our charting. Okay. All right. Any questions or suggestions or anything, guys? And so this is on the shared drive. If you have a registry coming in, make sure you're giving this to them or just sharing it with them so they kind of know, and let them know that you know, Medicare charting is every shift. It's not just, you know, odds and evens anymore. We're just doing it every
It
shift
seems like
to make sure.
I don't exceed it has been there.
Yeah, and
Most of
then
the time.
today I had a mirror actually in our meeting because I was kind of like showing her that this is what she needs to be auditing on. Okay, because she has a lot of stuff to audit, and so she's trying to catch up, but she just needs to audit even more. I don't, you know. So, anything else, Ricky? You guys sign in? Okay. Yeah, guys, you you actually get paid today if you came in, and they just put down here in the meeting and I'll add 2 hours in it for you. Okay. All right. Thank you so much. Yes, ma'am.
Did you see this?